Can you hear me okay? Thanks, Dr. Tsui, for inviting me here, and it's great to see some old friends and meet some new friends as well. So I want to talk to you about a topic that is dear to my heart for personal reasons, but also is a very common problem in the GI practice, but especially in the Asian population. So, and that is H. pylori. So I'll start with a case I had. You always get these things at 12 o'clock in the morning, and the first thing they tell you is, sorry to bother you, our patient's not doing very well. Very apologetic. So this is a patient who is a elderly gentleman who has coronary artery disease, has stents, and is on taking Plavix and aspirin, also diabetic, with melanoma, so black stool for 2 days. And after dinner, he had hematemesis, vomiting out fresh blood. So I examined, his lethargic, is definitely not looking good. He's hypotensive, tachycardic, is not on any anticoagulation. So that's a pretty high-risk patient here. The elderly on antiplatelets is hypotensive, is meet all the criteria for emergent intervention. So this is what I did actually. If I can I switch to a bit. Sorry, I'm trying to here. All right, so can you see it okay? You may have to lower the light in front, but so this is the endoscopy we did, how I did. So once you enter the stomach, what you see is, well, obviously a lot of fresh blood. So this in the antrum part, where you really can't see, can you? So fresh red blood. So something is actively bleeding. Now, so this is the bleeding source. If the picture shows up all right, you're supposed to see a bright red blood come out in the first portion of the duodenum, in the duodenum bulb. So where we know that's a high-risk lesion because of the gastroduodenal artery. So very high-risk lesion, and is actively bleeding. So the things I did then was first to tamponade it temporarily by injecting epinephrine. So what it does is sort of cushions the area and tamponade it temporarily. It's not a definitive therapy. So so this is what the technician is trying to do, is trying to inject the area. I'm just going to fast forward here. So once I've done that, the next step is two things you can do. One is the active coagulation, so you can use heater probe or gold probe for that matter. And this time I use something called an inner clip, which is recently available. So it's a metallic clip that you actually can get in there and close the blood vessel. So he's got a large ulcer with a protruding blood vessel that is actively bleeding. So I think I put a total of 3 clips in there to get this thing stop bleeding. So it took a while, and everybody's holding their breath, but he actually did well. I always biopsy the stomach, and this gentleman actually did have H. pylori and was treated. So if I can just fast forward here. So I want to start with a take-home message that I was taught how to give a talk. So you tell them what you're going to tell them, and then you explain, and then you tell them again. So H. pylori is very common, especially in the Asian population. Now there is definitely a risk factor for peptic ulcer disease, as we see in this case, especially duodenal ulcer. Now gastric cancer, which is a big problem, especially in the Asian population, and we'll sort of talk a little bit more about that. And gastric lymphoma, a very unique feature of H. pylori. Treatment is recommended in most cases Now, we need to document the cure. The other thing that is unique to the Asian population is something called gastric intestinal metaplasia. So the intestinal cells, small bowel cells, have migrated in the gastric tissue and replace that, especially multifocal intestinal metaplasia. The gastric atrophy, again, very common in the Asian population. So atrophic gastritis are the risk for gastric cancer even after you treated H. pylori. So I think we should consider upper endoscopy, especially in the high-risk population. Now, H. pylori is very important. It's so important that Dr. Marshall and Warren have been awarded Nobel Prize in 2005 for the discovery of H. pylori and association in gastritis and peptic ulcer disease. Now, it's not an easy thing to do, to a point that they had a hard time to convince the medical community and the scientific community for that matter. So Dr. Marshall has to volunteer himself, and he actually drank H. pylori, and 8 days later he had endoscopy done, and it did show a horrendous gastritis. And actually the picture on the left, well, on the right, well, on the left is a biopsy of Dr. Marshall's stomach. And on the right is a picture showing the H. pylori mostly living in the gastric pit. It's not an invasive organism, so it doesn't cause hemorrhagic gastritis or the GI bleed for that matter. There's another EM of H. pylori. The flagellus tails in there helps the H. pylori to sort of bury itself and go deep into the gastric mucosa. The site of infection, so this is the graph of the stomach, so gastric, I don't have to point to it, but the gastric antrum, the body, and fundus. So most of the infection are happening in the gastric antrum. So, come over here. In this area here, there's some other population, and also based on the treatment. There are other incidents that the H. pylori can migrate into the other part of the stomach, such in the body and the fundus. People can actually develop pangastritis. Some of them are affected by the treatment of PPI usage and antibiotics, so it causes sort of migration, if you will. Now the transmission, as it was said, being some rule, right? So yeah, so it's typically it's a person-to-person contact, especially with family. Most people with H. pylori actually got it before the age of 10. So I have a patient coming 55 with peptic ulcer disease. If I have H. pylori, they ask, oh, how did I get it? Did I get it from eating dinner with my friends? No, you probably had it since kindergarten. You just never had any problems until now. So that's clearly a person-to-person contact within the family, the fecal-oral transmission, in kids. But as I said, most people get it before the age of 10. Now the epidemiology, it's worldwide, and now the prevalence varies greatly. Now in our country varies, the prevalence is about 20 to 40% based on the population you're looking at. So in some rural areas, maybe less. In in the urban areas, maybe more. Partially is because due to the migration, but up to 80% population has been exposed in the developing countries. So this is the most recent map we have for H. pylori. So as you can see, the hot spot, if you will, are in Middle East, certain part of South America, Africa in some areas, certainly China and Southeast Asia, very high population. China alone has probably 50 to 70%, so very high prevalence. Now, the natural history of H. pylori, so I'll run this quickly. Once illness you acquired during the childhood is a longitudinal plot. So now people typically have high acid production at this point. Once H. pylori is transmitted, people develop acute infection. Now, most kids will present with viral gastroenteritis picture, and they rarely see a doctor. Now, most people will actually go on and develop chronic H. pylori infection. Now, as we said before, so there's an antral-predominant H. pylori. That's the risk factor for duodenal ulcers. It's much more common for gastric ulcer in the setting of H. pylori. Now, there is a pangastritis we talked about, and a body-predominant atrophic gastritis. So they're different, and also they're very important to differentiate, because some of the pangastritis, then people may go on to develop gastric lymphoma, we call it motoma, or some people are asymptomatic, they don't have any symptoms. Now, in the Asian population, we typically develop this atrophic gastritis. So when you do an endoscopy, you don't see any rugae, you don't see any of those nice mucosa. So it's very flat. You can see the blood vessels underneath. So the gastric tissue has become very thin and atrophic. And that's where people get in trouble with intestinal metaplasia, and later on will further develop into dysplasia and gastric cancer. So, and that's what we really worried about H. pylori, especially in the Asian population. So putting it into another different perspective, so initial infection, most people develop chronic gastritis based on where the H. pylori is at. So atrophic gastritis, peptic ulcer disease on the right, and motoma, which is gastric lymphoma. So some of the symptoms of it, certain recurrent abdominal pain. Now, I got this a lot from, certainly from primary care doctors, but people have recurrent epigastric pain, so it's not a sharp pain, it's not nausea, vomiting, or signs of overt GI bleed. People have abdominal bloating, they sort of burning after smaller meals, belching, sort of a discomfort and nagging discomfort. So some people, now we call it dyspepsia, so upper GI symptoms. Certainly, peptic ulcer disease, as indicated here, mostly duodenal ulcer because of where H. pylori is at. Now, in smaller cases, it's called gastric cancer and lymphoma. So peptic ulcer disease, H. pylori has been associated with peptic ulcer disease. Now in the US, about 3 to 5%. Now in elderly, maybe more because of other medication use, especially NSAIDs and aspirin and different antiplatelets. 25% to 30% in Asian populations. Now eradication is very important to prevent recurrent peptic ulcer disease, especially in the setting of the antiplatelet use. Gastric carcinoma, adenocarcinoma, certainly is definitely a risk factor. The WHO has classified H. pylori as a class 1 gastric cancer carcinogen in the early 90s. So people should, so that's another indication to treat H. pylori. So up to 3%, especially if you have a family history of gastric cancer. Gastric motoma, a type of B-cell lymphoma, has been associated with H. pylori. Actually, the treatment of H. pylori can lead to regression and complete eradication of gastric lymphoma. So, if caught early. Actually, I would treat people with H. pylori if they have gastric lymphoma, regardless if they have H. pylori or not. So gastric motoma, I'm just going to show some pictures. So this is the normal, healthy gastric mucosa. You see the rugae, and they sort of, they distend, they accommodate food when we eat. This is the case. So this, you can see this in just people with H. pylori. So this sort of a, I don't know if you can appreciate it, but it's sort of a nodular looking, they're sort of lumpy and bumpy. They look red and inflamed, and that's what H. pylori does. they trigger a very intense lymphoid reaction. And if you biopsy them, sometimes you see truck full of lymphocytes. So this is obviously an abnormal appearance. You see very thickened fold, some clean ulcer in there. Now this is a very advanced melanoma with very ulcerated gastric tissue. The gastric adenocarcinoma, they can just present with a little ulcer. You know, it doesn't have to be very big, doesn't have to be very impressive on endoscopy, but this ulcer, you can see the edges are indurated. Actually, if you touch it with biopsy, it's actually hard. So that's why we document the healing of gastric ulcers after the PPI treatment, because up to 5% of the gastric ulcers are a result of gastric cancer. So that's why you do that. Another case, this is very obvious, a very sort of lumpy-looking gastric mucosa ulcerated. This is a very advanced cancer with a necrotic appearance, gastric mucosa. So most gastric cancer at diagnosis, 75% are node positive. So they have very delayed presentation because of the size of the gastric volume. People don't feel any symptom until people get into this point. Either they're bleeding or weight loss, or satiety, those type of warning signs, so especially weight loss. So, indication for treatment of H. pylori, external hepatic ulcer disease, atrophic gastritis, if you find H. pylori, melanoma we talked about with gastric lymphoma, following resection of gastric cancer. Now there's some indication to treat people with H. pylori and maybe even screen them if they have a first-degree relative who have gastric cancer because of the risk. I mentioned anemia, there are some other indications. But most cases I treat H. pylori, I don't see any absolute contraindication not to treat it. It's hard, you know, 10 years from now, if somebody has gastric cancer and you know they have H. pylori. So why do we treat H. pylori? Because they lower the risk of gastric cancer. So this is a study performed a few years ago and looking at the meta-analysis, if you will, looking at different cohorts of patients. So from the lowest cohort to the highest. So even at the lowest cohort, if you look at the diamond, if you will, right there, it touches 1, so it's not statistically significant, but you can see it's definitely trained to lower the risk. So in the mid percentile, you can see that the diamond does not cross 1. Overall, if you combine everything, there is about 45 to 50% lower the risk of gastric cancer. So clearly indicated to treat H. pylori. So we'll talk about briefly about testing for H. pylori. I think we will know about this already. So they're basically the non-invasive tests, the breast test and fecal antigen test. I got this a lot in terms of what should I use. They're very similar in terms of sensitivity and specificity, just based on patient preferences. The breast test is sometimes harder to order based on the laboratories available. But if you look at sensitivity and specificity itself, the breast test and the stool antigen very close, 95% for both. Certainly upper endoscopy biopsy are the gold standard. But typically that's what I use. The serology, I don't really use them much at all because they remain positive for a long time, even after treatment. So primarily non-invasive test, breast and stool testing. The things we all know is to have patients avoid any type of anti-acid, PPIs, and other H2 blockers, even Pepto-Bismol for 2 weeks, no antibiotic of any form for 4 weeks before the testing. because of false negatives if people are taking those medicines, due to the fact that those medicines suppress H. pylori. Treatment, now a few years, this new guideline from GI, a few years ago, there were a triple therapy, I think it's called PAC, which is PPIs, amoxicillin, and clarithromycin. It's no longer indicated as first line, and one of the reasons is because of antibiotic resistance to H. pylori, especially to clarithromycin. It's up to 40% even higher. So the first line treatment is quadruple therapy, based on any form of PPIs, pepto-bismol, flagyl, and tetracycline. There is a commercial product available. It's called Pylori. Now, the commercial preparation is for 10 days. The guideline calls for 14. So sometimes I'll just write on another 4 days course of this quadruple therapy, but 10 days do most of the trick. Now, I got referred quite a bit in terms of people who have recurrent H. pylori. They got treated for triple therapy once, and then twice, sometimes third times before they come in to see me. So if you treat it one time, if your document is still present, it's not they acquire it again. It's because you never cured it in the first place. It's very hard to get, impossible. It's very hard to get H. pylori if you cure it. It's less than 1% chance. Adult patient, if you cure it, then they're going to require it again, unless you're Dr. Marshall who trained H. pylori. But people who fail quadruple therapy, one of my favorites is the levaquin-based therapy, PPI, amoxicillin twice a day, and tetracycline. And levaquin, I sometimes use 250 BID for 14 days. They're pretty good and effective way. If that failed again, then it's a little bit tough to do. You have to look at the sensitivity and things like that. Okay. Now we talk about gastric intestinal metaplasia and gastric cancer. So again, this is a very common, especially in Asian population. So in terms of our GI society, in the general Caucasian population, if you do upper endoscopy and incidentally find gastric intestinal metaplasia, the controversy is there, and most GI society would say you don't need to do anything with it, especially if you just find a focal intestinal metaplasia. But the story is different in the Asian population. I think it applies to a higher risk population as well. Now, this is demonstrated in this study, I think a year ago. It's a high-risk population in Japanese population, a 600 patient who had H. pylori treatment, and they were cured, and they were followed for 7 to 6 years. Now, they all had endoscopy. And one reason they had endoscopy is to see whether or not they have intestinal metaplasia, and the things we talk about is gastric atrophy, so atrophic gastritis. So the question is, if they had intestinal metaplasia and gastric atrophy, what else do? You cure them for H. pylori. Well, so the study showed after 5 years, if the patient has no intestinal metaplasia or no atrophy or very mild atrophy, so the risk of gastric cancer is very low, less than 1%. So in contrary, if you have multifocal intestinal metaplasia, where I would do biopsies, I would do something called gastric mapping. So, but if 2 or 3 sites had intestinal metaplasia, means in this high-risk population, there are up to 9% to 10% people who develop gastric cancer, especially in the setting of a severe atrophic gastritis. Those things typically go hand in hand, the atrophic gastritis and intestinal metaplasia. So the conclusion of this study is, so pre-existing intestinal metaplasia, and especially significant gastric atrophy, is a risk factor for H. pylori, for gastric cancer. So which begs the question is, shall we do gastric surveillance? And some leaders in the GI society think yes, actually, especially in the high-risk population. The guideline is not clear in terms of when should you do it, how many years. 2-3 years is typically the general census where you have to do gastric mapping. So, and most GI I think most GI trained, most US trained GI doc don't do gastric mapping. They would take two biopsies from antrum, maybe another one from gastric body, and that's not enough for gastric mapping. So you have to at least take 20 sites and put them in separate bottles for the pathologist to help you. So, so in summary, H. pylori is very common, especially in the Asian population. It's a risk factor for peptic ulcer disease, gastric area carcinoma, and melanoma. Treatment is indicated for most cases. That you need to document the cure with either of those non-invasive tests. We talked about the gastric intestinal metaplasia and atrophic gastritis in the high-risk patient. And definitely consider upper endoscopy in a high-risk patient. So the argument for that is, yes, you can treat H. pylori by doing stool testing, but you have no idea whether or not they have intestinal metaplasia or gastric atrophy. So consider doing upper endoscopy in a high-risk population. Surveillance, so I typically survey them if they have multifocal intestinal metaplasia every 2 to 3 years, not more frequent than that. Thanks for your attention. Questions?
Okay, the next speaker is Dr. Lam. While he's preparing his slides, we have an announcement.
Hello, good morning. Yeah, I'm Dr. Xiao. Probably everybody's wondering who's that woman all the time standing up and pose, Yeah, I'm Dr. Xiao. I'm a psychiatrist. I'm a staff psychiatrist.